Federico, do you want to get this started? Thank you so much. So my name is Paul Bonato. I'm the editor-in-chief of IEEE OJEMB. Professor Dieter Emmerich and Professor Punit Prakash serve as the guest editors of this excellent special issue that we pulled together a few months back. The authors are going to present individual papers, but Dieter and Punit are very well known in the field, so I'm not going to waste time making introductions here. I'm just going to give the floor to them, and I'm going to thank them very much for both organizing this excellent special issue as well as for coordinating activities for the webinars today. So Dieter and Punit, the floor is yours. Thank you so much.
I think Punit is going to head and introduce the first two speakers. I introduce the last two speakers. To remind all the attendees, we're going to do the Q&A session at the end. Please post your questions in the Q&A box, and we'll try to get to as many as we can after all the presentations I've finalized. And I think with that, I'll hand it over to Punit to introduce the first speaker.
Okay, thanks, Dieter, and thank you to everyone, all the attendees, as well as the authors for this special issue for joining us for this webinar. So our first speaker will be Frank-Angel Severin from Biomedical Engineering at Vanderbilt University, and he'll be presenting to us about the really interesting paper on digital twins for computational modeling of microwave ablation procedures. So please, Frank-Angel, the floor is yours.
Can you hear me now? Perfect. So, hello, my name is Frank-Angel Severin, and my work is titled Simulation of Image-Guided Microwave Ablation Therapy Using a Digital Twin Computational Model. Here, I will present my work on using computational models to forecast ablation therapy to treat liver cancer. To begin, why is liver cancer so concerning? Well, it is the fourth most common cancer. Of over 41,000 cases from last year, over 70% were HCC. Additionally, non-alcoholic fatty liver disease, NFALD, is prevalent in patients with HCC. A popular treatment is microwave ablation, which is minimally invasive that desiccates tumor tissue. A primary clinical challenge with this procedure, however, is that tumor recurrence is 15 to 30% for tumors greater than 3 centimeters due to incomplete tumor coverage. An identified gap of this therapy is that thermal dose is calibrated to healthy tissue. But as you may know, many patients do not have healthy livers. Fortunately, we can bridge this gap using digital twins. First, what is a digital twin? Well, as I describe it, a digital twin is a virtual representation of a patient. It is created using data from medical records, diagnostic imaging, and other sources, and it provides a comprehensive view of the patient's health and lifestyle, allowing for greater predictions, and as we all know, certainty leads to success. To create my digital twin, I have to thoroughly develop a complete and functional framework. First, patient data scans were carefully segmented and utilized to provide foundational data. These scans were used to develop spatially distributed maps of material properties, and the liver segmentations were used to create a mesh for my finite element simulations. Additionally, I segmented the hepatic and portal veins to identify placement strategies as they are a major navigation concern. And altogether, this process creates a comprehensive digital twin of liver ablation. We conducted an in-depth investigation of tumor coverage at the two most used antenna frequencies, 915 megahertz and 2.45 gigahertz, analyzing the effects by toggling tumor properties for a scenario modeling tumor-specific properties, tumor-informed, and a scenario ignoring tumor properties, tumor-naive. In this work, the specific patient was determined to have mild fatty liver disease. I created additional hypothetical scenarios to represent other liver disease states using retrospective data. We had previous experimental results fitting ablation relevant material properties based on fat content, which is thermal conductivity, relative permittivity, electrical conductivity, and blood perfusion. Using this data, we will define our modeling domain as homogeneous tissue. So, for example, a domain of a low-fat liver would be defined by the values circled in blue, and the domain of a high-fat liver would be defined by the single values circled in purple. For this work, I simulated 4 antenna placement strategies. To maintain clinical guidelines, all antenna trajectories were greater than 5 millimeters away from the vasculature and angled as close to the coronal plane as possible for accessibility. Additionally, all placements targeted the center of the tumor. This figure illustrates the orientations of the candidate placements. So with 4 placements at 5 fat contents with 2 antenna models and 2 tumor models, I completed a total of 80 simulations. To the right, I visualized the ablation volumes in the context of the entire system, which we were primarily concerned about was calculating tumor coverage. So here's how I analyzed ablation volumes. I use a standard long axis and short axis measurement, which is in my paper if you're interested in seeing it. Additionally, I used sign distance to agreement to analyze ablation conformity. This is an edge-to-edge metric to visualize and illustrate the distribution of intersection. In this metric, negative values correspond to a target intersection, and positive values correspond to regions without intersection. Sign distance is an established method in radiotherapy to assess tumor coverage and is now being adopted in other disciplines for similar analysis. Here, I will briefly show you that I conducted results of all placement strategies. If you want to know more, you can read my paper, it's great. But from here on out, I will focus on the placement and scenarios that resulted in the greatest ablations only. And overall, the high fat liver scenario resulted in the greatest ablation, and placement A was the best. So looking at placement A and high fat scenarios, for the 915 megahertz antenna, the tumor naive model without tumor specific properties demonstrated a 45 to 70% tumor coverage. In the tumor informed digital twins, coverage was around 40 to 70%. The sign distance to agreement between the ablation and the tumor in both models was similar, and the margin extended 30 to 35 millimeters beyond the tumor, which can be problematic. So overall, I would consider this performance to be mixed, since across all placement strategies, coverage was about 50 to 65% at the most optimistic. In the 2.45 gigahertz antenna, the tumor naive models demonstrated a 70 to 90% tumor coverage. And in the tumor informed digital twins, it was 80 to 95%, where the maximum sign distance was between 17 to 15 millimeters across all placement strategies in both models. So here would be a much better choice for this specific patient. And overall, approximately 60 to 80% of the total ablated tissue was tumor across all orientations. You can even see the better coverage in the medial and superior regions of the tumor. So side by side, here are the major results for both antenna frequencies and tumor models. For the 915 megahertz antenna, both models demonstrated a 45 to 70% tumor coverage. Conversely, the 2.45 gigahertz antenna tumor naive models demonstrated a 70 to 90% coverage, while the tumor informed digital twins had a coverage of 80 to 95%, indicating that tumor properties for this antenna model does affect predictions. So to discuss my major findings, the 950 megahertz antenna produced ellipsoidal ablation that was not affected when modeling tumor properties. The 2.45 gigahertz antenna had a much larger ablation volumes in the presence of tumor properties, and this suggests that the relationship between tissue properties and conformity can be specific to antenna models, which is an intriguing finding. But one thing to note is that none of the ablations completely covered or treated entire regions of the tumor, which is problematic. If we targeted specific regions potentially instead of the center, it would be possible to better control tumor remnant. And if we interrogate the concept of targeting, multiple antenna ablation is currently being used, but predicting these large margins are uncertain. And currently, right now, we have the ability to do these procedures, but forecasting is really uncertain. But I can leverage digital twins to investigate these margins and enhance the utility of this therapy. And I'm currently investigating this application of digital twins for the specific purpose and potentially incorporating machine learned capabilities for unique placement strategies and predictions. And for this work, I would like to thank everyone in my lab and my VUMC collaborators. Without them, this work would not be possible. Thank you very much.
Well, thanks very much, Frank and Joe, for that excellent presentation. So for everyone in the audience, as was mentioned earlier, if you could please put your questions in the Q&A box. We'll take them all together for all the presentations at the end as part of the panel discussion. So our next speaker is Ali Farshkaran from the University of Texas at Austin, and he'll be presenting the group's paper on a microwave-based technique for bladder state estimation. Thank you.
Hello, everyone. Please let me know just if you have the screen and the sound. No problem. Okay, nice. Hi, everyone. Today I'm going to talk about the work that I did for my PhD. As part of my PhD, it's about detecting bladder state using microwave technology. For this work, we are using realistic models. The motivation for this work is that urinary incontinence is a kind of worldwide problem. And in order to help it, there are different tools, different commercial tools that are available. However, microwave-based methods are more promising as they are non-invasive, usually cost-effective, and they are very compatible with wearable designs. The other available ones, like ultrasound, are working as well. However, there are some problems regarding usage, long-term usage by the individual themselves. In order to kind of further study the microwave part, we try to create a simulation-based study. Currently, there are a few studies in the literature. However, they are usually simplified. They use layered models or simplified 2D models. Also, there are different problems regarding the tissue properties reported in the research. So we try to study the effect of the properties for urine in this case. And our aim is to be able to create a microwave-based process to be able to detect the bladder state for both male and female models. So in order to do the simulations, we are doing 3D full wave simulations on HFSS, FEM-based simulations. In order to create the models, we are using the voxel-based models, Austin Man, Austin Woman, which was created in the University of Texas at Austin. We convert the voxel-based model to surface-based models using marching cube algorithms and later refining the mesh using open source softwares. So on the right side, you can see the models created for pelvic regions. On the first row, we have the male model. Second row, we have the female model. The total tissues are simplified to 6 tissues in this model, which is skin, fat, muscle, bone, bladder wall, and urine. And we have models for empty bladder, half full bladder, and full bladder. And the data for fullness of the bladder are from different papers. Finally, in order to do the simulations, we considered planar antennas, which were designed previously for breast cancer detection. However, based on the tissues and the frequencies that we are working, there's a very good match for pelvic region as well. We have 4 antennas in front and 4 antennas on the back of the model. And based on the radiation pattern of the antenna, the near field levels of antenna, we optimize the models by cutting places where the fields were less than 60 dB from the max fields. And the aim is to analyze data based on scattering parameters or reconstructed images. Checking different S parameters, both reflection-based and transmission-based, there were differences between empty and full cases for different cases of urine properties. However, we couldn't see a specific pattern, and it was very difficult just to decide based on reflection coefficient themselves. I should mention that later we tried using machine learning classification, and we got very good results. However, just by considering the S parameters without any kind of post-processing, it was difficult to decide about the state of the bladder. However, we tried using image reconstruction. For this, we used open source microwave radar-based imaging toolbox, Merit. The reference is available in the paper as well. This algorithm uses a delay and sum algorithm to reconstruct an image. So we consider a layer in our structure, and we define channels between antennas. It can be a reflection coefficient from one single antenna to itself, or transmission coefficient between different antennas. The data we have are frequency domain result data, and at the same time, in order to use this algorithm, we are considering an average permittivity for the region that we are trying to solve. So it is initially simplified. However, based on the results, we can see that when considering the signals as the data from channels between full and empty cases, simply subtracting them, we can recreate the image where shows the difference in properties that creates the difference in reflection coefficients. And with this, we can see that detecting full bladder is possible using microwave antennas. Here, it was not simple to detect half full bladder. However, there are a couple of reasons for that. One of them is that obviously the volumes of the half full is much smaller than the full bladder, almost less than half. And at the same time, it really depends on the layer that we are trying to reconstruct the image. These layers are selected at the middle of the full bladder, which was outside of both empty and half full bladder. So to conclude this work, we kind of represented a microwave-based algorithm based on realistic models. We did not study the effect of antenna itself. This antenna worked for us, but however, as a future work, we are trying to see if there are better and optimized antenna models, configurations, frequencies, and so on. Thank you.
Thank you very much, Ali, for a great presentation. Our next presenter will be Piper Canon from Vanderbilt University, and Piper will present the SAFE framework for quantitative in vivo human evaluation of image guidance.
Let's see, am I good to go? Can everyone see my presentation? Okay, hi everybody, I'm Piper Canon. I'm a PhD student in the Med Lab at Vanderbilt University, and I'm excited to share our recent work where we present a safe testing framework to quantitatively evaluate image guidance systems in vivo. We're also going to demonstrate this framework as applied to robotically assisted partial nephrectomy. Robotic surgery has transformed modern medical practice as it enables minimally invasive procedures for complex surgeries. But even with advanced systems such as the Da Vinci, surgeons often rely on preoperative imaging to understand subsurface anatomy throughout the procedure. Translating these static 2D images into an accurate 3D mental model during surgery is a cognitively demanding task. So what if we could provide surgeons with a 3D map? Also, is my presentation updating for you guys? Okay, cool. What if we could provide surgeons with a 3D map of anatomy to make minimally invasive robotic surgeries more accessible? On the right is an example of a surgeon leveraging three-dimensional anatomical models to better orient themselves during their case with the Da Vinci robot. But as you can imagine, the benefit of these images are limited as they can't be updated in real time and aren't integrated into the surgeon console. Our image-guided surgical or IGS system displayed on the right addresses surgeons' need for improved intraoperative anatomical information by displaying patient-specific anatomical models relative to the robotic instruments in real time. While both our image guidance system and our novel in vivo testing protocol could be applied to a variety of surgeries and systems, our work is specifically motivated by the clinical need to make robotically assisted partial nephrectomies more accessible. This procedure greatly improves patient survival and quality of life, but it is a challenging procedure that requires precise localization of subsurface structures. Thus, we demonstrate our IGS system and in vivo testing protocol during robotically assisted partial nephrectomies to gain both qualitative and quantitative in vivo insights. Before we can deploy our system, we generate patient-specific anatomical models from preoperative images using standard segmentation methods. To align the model with the surgical anatomy, we employ touch-based image registration. Here, we leverage the robotic tool to digitize the anatomical surface. The resulting point cloud is used to align the model via the iterative closest point algorithm. In prior work, we used phantoms to evaluate our system, which is the most common and accessible method for IGS system assessment. Here, we validated our touch-based registration method and our system's impact on the surgeon's ability to localize endophytic targets and exophytic targets. On the left side of this mean error plot, we see that our image guidance system, which is represented by the red bar, vastly improved the surgeon's ability to localize subsurface targets. For our surface or exophytic targets on the right side of the plot, we see that our system improves the surgeon's localizations when the targets are covered by fat, which is represented by the blue bar, and does just as well when the targets are uncovered and can be directly visualized, which is the yellow bar. While phantom studies are accessible and help us gain insight into IGS system development, we know that they don't fully capture the in vivo surgical setting. Researchers in the field have evaluated IGS systems in vivo based on clinical metrics and qualitative outcomes, but quantitative data is lacking in the literature. To address this gap, we present an experimental framework we call the bystander protocol that enables image guidance systems to be safely tested quantitatively in vivo. The bystander protocol consists of two surgeons trading places at various points throughout a surgical procedure. The primary surgeon performs all aspects of the surgery, but they never see our image guidance display. The bystander has access to the image guidance and collects data using it, but does not perform any surgical actions. Following this workflow, the primary surgeon can also make measurements without seeing the IGS display, and the results can be compared between the two surgeons. Thus, this protocol enables us to quantitatively test any image guidance system in vivo without posing undue risk to the patient or altering their care. It's important to note that this protocol can be applied to any image guidance system regardless of the surgical application. I'm going to quickly step through how we applied the bystander protocol to robotic partial nephrectomy, so there's going to be a few slides with graphic videos. To start our experimental protocol, the primary surgeon begins their standard dissection while also exposing a portion of the kidney surface to clear the way for our touch-based registration. Then the primary surgeon and the bystander trade places so that the bystander can lightly trace and digitize the kidney surface. They also place cautery and ink fiducials to enable quick registration updates throughout the experiment. Once the tracing is complete, we run the ICP algorithm and the model will be aligned with the anatomy. Then the bystander can use the endoscopic video feed and the image guidance display to point at subsurface targets, similarly to how we did in phantoms. In this clip, they're localizing the tumor centroid, the planned arterial clamp location, and the intersection of the inferior vena cava and the renal vein. The bystander and the primary swap places again, and the image guidance display is turned off so that the primary surgeon can point at those same targets, which are covered by fat. Then the primary surgeon continues with their standard dissection, uncovering anatomical targets as much as possible in the process. Now that the targets are uncovered as much as they can be, the primary surgeon localizes the targets for a final time via direct visualization to give us a sort of quasi-ground truth to compare the previous pointings to. Our in vivo study included 6 robotically assisted partial nephrectomies. Here we have the mean target localization errors for the targets across all the cases. We define the TLE as the minimum perpendicular distances between the final measured point of the target as determined by that last set of primary pointings, and then the lines defined by each primary and bystander pointing instance while the targets were covered. Here's the lesion centroid localization errors, followed by the artery and vein localization errors. Then the final anatomical target we considered was the intersection of the curve of the lesion with the healthy kidney tissue. Our novel in vivo bystander testing approach enabled us to quantitatively evaluate our robotic image guidance system in vivo and glean important lessons from these results. Based on the lesion centroid result, we realized a significant source of error is associated with the human's ability to even point at a desired target with the Da Vinci tool. We conducted a separate study where we found that attempting to point at the centroid of a sphere that's roughly the size of the tumor in this study introduces an error of up to 5.21 millimeters. Further, we learned that overall registration error does contribute to the TLE metric. In this series of studies, we utilized rigid registration, so the anatomical model didn't totally capture the anatomy's deformation, which was adequate in phantoms, but not in vivo. Due to this deformation, we added the lesion parenchyma target in our final 2 studies. We are using the insights gained, some of which are unique to the human testing, to directly inform our next generation system design. The bystander protocol, which is agnostic to target anatomy, source of images, and registration method, enabled us to quantitatively take measurements in vivo and yielded useful insights to inform our next design of our system. The leap from phantoms to human studies introduces a unique set of challenges, including tissue deformation, variability in patient anatomy, and the complexity of the surgical environment. Here we demonstrate the bystander protocol and its utility as a robust framework for evaluating any image guidance system in human subjects, paving the way for advancements that will enhance accuracy, safety, and the overall impact of image-guided surgery. I'd like to acknowledge my collaborators that contributed to this work, as well as the Vanderbilt Institute of Engineering for providing their time and resources. Also, we were funded by the NIH. Thank you.
Thank you very much, Piper, for a wonderful presentation. Our next presenter is Dr. Matteo Lordi from the University of Cagliari in Italy, and he will present on the evaluation of hypothermic efficiency of magnetic scaffolds.
Yes, let me share my screen. So thank you for being here, for having me here. So just a moment. Okay, sorry for this technical issue. So just a moment. Okay. So can you see my screen?
Yes, but it's in presenter mode, I think.
Okay, so let me share the other screen. Just a moment again. Sorry for that. Then I missed the Zoom. Okay, so this should be the right screen. So this work is a collaboration between University of Cagliari and the University of Thessaloniki, the Aristotle University. I will introduce you this problem, since it is a different kind of therapy related to thermal treatment of bone tumors, explain the concept behind the integration of numerical studies and the experimental protocols that is proposed to assess the therapeutic potential of these new kind of biomedical devices. So basically, some tumors, like deep-seated tumors, such as bone cancers, are very insensitive to chemotherapeutics and radiotherapy. And most of them, primary and secondary tumors, are always subject to survival rates that are very low and high recurrence rate. Since the clinical management of this kind of tumors calls for surgical operation, such as resection or curettages, etc., a graft, a scaffold, some biomaterial is always needed. But since the recurrence rate are high, there is the problem of treating residual cells in the surgical bed after the tumor resection. New therapies, such as hyperthermia treatment, that are based on the temperature elevation in some target tissue, are prominent, are very helpful in achieving direct cell killing and exerting some biological effects that are related to pH modification, improved tissue blood perfusion, enhanced oxygenation, and some elicitation of the immune system response can be used to increase the radiotherapy and chemotherapy effectiveness. Hyperthermia treatment can be administered using electromagnetic fields in the radiofrequency or microwave regime. Some of these techniques are limited depending on the heating depth and the tumor target size. So even though there is a clinical value in using this kind of therapy, there is some limitation in this application. So hyperthermia treatment has never been or poorly been used against bone tumors. But since you need this graft, this biomaterial, if you make a biomaterial that is responsive to the electromagnetic field, in particular using magnetic particles, micromagnetic or nanoparticles, you can get a device, a graft that can treat in situ after the surgical resection and after the implantation the residual cancer cells, using some radiofrequency magnetic field and increasing the temperature up to 42, 45 Celsius degrees and achieving local hyperthermia. After the tumor treatment, you still have a biomaterial that can be used for tissue repair. So this multifunctional class of magnetic materials have been studied and their use has been proposed. But when you try to compare in the literature all the works related to these magnetic scaffolds, so-called magnetic scaffolds, the hyperthermic potential, the way they can perform and behave under hyperthermic condition is very variable. So we have very different type of biomaterials, biopolymers and bioceramics, different type of magnetic phases, very different frequencies, different field levels that are used. And so the temperature range, that is the clinical quantity of interest, is very variable. Since the way of measuring these temperature are very different, and these samples, these magnetic scaffolds were tested in very different media, the specific absorption rate, that is a quantity, dosimetric quantity that we can use to understand how good is a magnetic scaffolds for the treatment, are very variable. So we studied how can we standardize and achieve a robust and practice methodology for estimating the specific absorption rate. So let's go to the numerical multiphysics studies, because in a previous work we tested different media, different conditions. So we put some magnetic scaffolds in air, in water, and in an agarose phantom, and we found that the variability was very, very high in these three different environments. In water, convection starts to initiate, and so the temperature changed a lot. So we could control the exposure under agar condition. However, how to place the sample and where to measure the temperature was a problem. So we implemented a finite element method simulation setup to account for an homogeneous cylinder having 2 centimeters in diameter and in height, coupling the Maxwell's equation in the frequency domain to the heat transfer equation, and solving the system, varying the position of the scaffold along the axis of the agar phantom and along the radial position, to account for the uncertainty that we could have on the estimation of the specific absorption rate. To do so, in the simulation, we used some data found in the literature for the thermal property of agar and other materials, and we measured the magnetic property, magnetic response in the static regime of some ferromagnetic polymers based on polylactic acid that are commercially available and that we could 3D print and use in the experimental part. The results from the simulations report that changing the position along the axis of the coil and in the agar sample will imply a SAR variation of 2–4%, which is pretty much, and this is due to the loss of field homogeneity of the sample inside the coil. So it is affecting the coupling between the coil and the sample. And for what concerns the displacement along the radial position, the small variation of about 3 millimeters could lead to 8% in SAR values. So combining these two effects together, we could have a 10% variation if the sample is misplaced in this kind of setup. So the idea is to put the sample in a central position in an agarose phantom and to sample the temperature in different positions, at least 4 positions, one in the center of the sample, one on the left, on the right, and record also the temperature in the agarose phantom. So not only inside this polymeric porous biomaterial, but also outside. And then estimate the SAR values using the average values between those temperature records. What we found is that the SAR in this way, using the averaging methodology, could be more robustly estimated, and we would not lead to a 20% uncertainty in this value. And so the proposal, to conclude, is that to account for the clinical potential of these magnetic scaffolds, the idea is to understand what is the best magnetic scaffolds. To do so, we need to estimate the specific absorption rate under control condition, and we proposed an agarose-based experimental setup using multiple temperature readings to reduce the error on the specific absorption rate. So thank you for your attention.
Thank you very much, Dr. Lordi, for a great presentation. Appreciate it. A final reminder for all attendees to please post any questions using Q&A functionality in Zoom. And with that, it's my pleasure to introduce our final speaker today, Dr. Joachim Gri from the Fraunhofer Institute for Digital Medicine, MEVIS, out of Bremen in Germany. And he will present on the validation of a finite element simulation for predicting individual knee joint kinematics. Thank you.
Yeah, thank you for the introduction and a warm welcome to all participants from Bremen City. So as already mentioned, I will present our work on the finite element simulation for the knee joint kinematics, and it's a good time point for the presentation because this year, October, we received the research award from the German Society of Orthopedics and Trauma Surgery for digitalization in orthopedics and trauma surgery. So it was a nice peak in the views of our paper in the last weeks due to that. So let me introduce the knee joint. It's one of the most complex joints in the human body. We have the bone parts, patella, femur, tibia, and fibula, as well as the cartilage, menisci, and the ligaments, ACL and PCL, the most common, but also the medial and lateral collateral ligaments. There are many common injuries of the knee joint regarding ruptures of the ligament or defects in cartilage or meniscus. In Germany, there are 25,000 ACL reconstructions per year, and there's a problem with this kind of operation because 50 to 70% of patients evolve arthrosis later on in their lifetime. And that arthrosis is a big problem for society because of loss of paid work due to patients being not able to come to work. So the aim for individualized care for knee joint is to enable better reconstructions of the ACL, restoring the physiological movement of the knee joint, and by that improve the long-term outcome for the patients and also reduce the costs in the public health services. So the approach we did together in this project with the University Hospital of Freiburg is that we did measurements in the MRI, which you see on the left-hand side using a loading device where you put prescribed loading positions on the patient's knee joint. We had extension, flexion of 20 to 30 degrees, and then internal, external rotation of the foot, as well as varus valgus load on the knee joint. On the right-hand side, you see the raw images taken in all of these different positions. And what we did for the modeling is that from the knee joint image in the straight position, we built up a model with all of the relevant anatomical structures and use the finite element simulation method to predict the different knee joint states, the different knee joint poses starting from this model. Now, the approach you are seeing here is that we used tetrahedral measures as seen on the right-hand side for all of the relevant volumetric structures. We applied different material laws for the structures. The bones are rigid bodies, cartilage are linear elastic isotropic materials, menisci are linear elastic anisotropic materials, as well as ligament and tendons with hyperelastic anisotropic materials. For the ligaments, we also applied pre-strain according to the literature values. We have found we had sliding contact conditions between all of the different parts of the knee joints and some boundary conditions for the footprints of the ligaments and the cartilage, as well as the meniscal horns to fixate the menisci. So the aim is to predict different positions, mainly based on the strains in the ligament, because the knee joint movement is not only a rotational movement, but it's a mixture of sliding and rotational movement that we want to analyze on an individual level. So in order to do so, we represent the knee joint with a so-called cylindrical coordinate system, where we have all of the different rotational parts, so the flexion of the knee joints, the varus valgus rotation, as well as internal, external rotation of the foot, together with the translational components in the respective axis directions. What you see on this plot right now is a comparison of the predictions of the finite element model versus the measurements we did the MRI loading device in the respective position. So the finite element simulation is a green line, the MR measurement is a blue line. You see here the angle flexion is something we prescribed. You see here we have a sequence where we go in straight overstretched position, then we go in flexion of 20 degrees. And after that, you see in the rotation part, we go into external rotation of the knee joint, just as one example movement. The angles, flexion and rotation are prescribed for the model. The other parameters are all free. So you see here divergence of the deformities of the varus valgus angle from the simulation to the measurements in the MRI. And the more interesting part is if you look at the translation parts, we see that the lines are quite close together, but of course we see a few differences, especially you see here the translation in anterior-posterior direction. We have a large sliding movements during flexion of the knee joint, which we see both in the simulation as well in the measurements with the MRI. So we did a detailed analysis on all of the different parameters, and so the angle deformity in the different states we have simulated, as well as the different translation components, where the clinical most relevant is that anterior-posterior translation, as already mentioned. What you see here that the errors are in the order of a few millimeters for the translation. We see a variability over the individual patients. In that cohort we have analyzed here, we had 11 healthy volunteers measured with this setup. We also did analysis of the errors with respect to the surface distance between the position of the bones in MRI and the position predicted by the simulation model, and we see quite similar results as for the rotational and translational parts I have shown you in the previous slides. So let me summarize the findings. We have developed the simulation method to be used for pathologies on the knee joint by specific MR images, and we validated this model with an approach based on the loading device, where we did measurements in the MRI on specific positions. And what the benefit of the approach is, we can do analysis of ligament strains with the help of the model, which helps surgeons in their planning. The average translation error of the model was about 2 millimeters, and the average angular accuracy was about 1 degree, which is very suitable for being used for planning on an individual level of surgeries of injuries of the knee joint. So with that, I thank you for your attention, and if you have any questions, please contact me also later on via email.
Thank you very much, Dr. Georgi, for an excellent presentation, and congratulations on your award as well.
Thank you.
So with that, I think we're going to go into our simple panel discussion. Again, if anyone has any questions, please post them using the Q&A functionality in Zoom. Maybe I'll start out with a general question that any of the presenters who would like to contribute can answer. So quite a few of you have used patient-specific models, and very few patient-specific models are currently used in the clinics because it's a very complex process. So where do you see the bottlenecks, or what do you think would be necessary to get them more widely used for actual patient simulation, including, for example, going from images to model geometry, simulation time, or patient properties, any other aspects you think would need to be addressed before we could use it more widely?
I have a few thoughts on this question. So for one, in my perspective of digital twin modeling, which is what I kind of call my work because I'm, again, the patient specificity to predict a very specific outcome to their properties. One great advantage of these models is that they actually allow us to explore the variety of outcomes with disease states. So sometimes one of the questions of bridging a clinical gap is actually exploring just how necessary it is to actually model every single aspect of like patient geometries or tumor properties. For example, in my work, we've kind of analyzed the encoding heterogeneous properties versus homogeneous properties for liver disease. But in the patients that we have, they had a very diffuse presentation of the fat was very evenly distributed in their liver. And so the difference between modeling homogeneous versus heterogeneous was negligible, essentially. And that was a very interesting aspect to explore so that we can determine, well, this is not entirely necessary and also reduces computation time. And so it's a very useful tool to actually investigate what properties actually matter that affect therapy.
Thank you. I think Joachim had your hand up as well earlier to share some thoughts.
Yes, that was an excellent question, and I want to elaborate a little bit on our plans on that, because it's really difficult to get patient individual models into clinical practice, especially finite element-based models. So for what I showed, we have also developed a simpler model based on position-based dynamics, a simple simulation approach, but with a big advantage that we have a pipeline that within a few seconds we can generate this model directly out of the MRI images used in clinics. And we developed both of these models in parallel, and the finite element model was more the basis for validation of the more simpler model that can be more easily used in the clinicals. Also with respect to runtime, the finite element simulation depends a few hours on a powerful machine, where the simpler simulation model can just run in a few seconds for the case. So you can really do imaging, then to set up the model, you can analyze the kinematics and go into the surgery. So that fits more into the workflow than to be interrupted by waiting for feedback of the simulation to prepare some results, and maybe even worse, to have some engineers checking the meshing of the finite elements, the convergence, setting it all up before you can use it. So I think these are important developments to get it faster and more streamlined way into the clinics.
Yep. Another thought, and I wonder what everyone and the speakers think as well, is potential. This, Joachim, you mentioned sound like sort of a surrogate modeling approach, or a simplified model with more rapid runtime that you could then benchmark against your finite element model. And I think in one of the presentations, I think it was a bladder state estimation. I think Ali's presentation, you mentioned using sort of rather than representing the full detail of the human pelvis, using an average electromagnetic properties for your simulations. Was the motivation there to reduce runtime, or the lack of properties for detailed structure? I don't know if you could shed some light on that.
Essentially, the model was detailed, so there was no problem with the details or the properties, at least within the tissues that we used in the simulation. But the challenge was this toolbox, the open source toolbox, is not very compatible with the random shaped structures. So it was challenging to define different regions with different properties, especially within the pelvic region. Like intestines have a very complicated shape, and there are no dielectric properties defined for intestines, and the closest ones they use usually muscle for intestines as well. So there's this really complicated region with fat and muscle, which for simulation itself, it caused a lot of problem just to be able to well define those regions. So that was the challenging part in the imaging part that was not trivial to handle. However, the most basic step was to use just a general global average to see if it works or not. And luckily for us, it worked with the average itself. But if it didn't work, the next step would be just to try to at least create a simplified layered model or materials to be able to check that, because the first layer is always skin, the second layer is always fat, then muscle, and bone and bladder are within that. So a little kind of simplified model would help a lot as well.
A quick question for Piper, maybe. So you showed some very nice data on nephrectomy. I was wondering, are you currently working on other procedures where you implement the same approach, or what are your next steps with your system?
Yeah, so for our system, we're still just applying it to robotically assisted partial nephrectomy. That's one of the cases our clinical collaborators do pretty frequently with the Da Vinci robot. So as far as we're concerned, we are taking some of the things we learned from our last round of human studies and putting that into our next generation of our system. So we're looking at things like deformable registration, kind of to your question before, like it'll be quite a bottleneck to be able to do that in real time. So that's going to be one of our big areas of work coming up. But yeah, so we're just working on developing our system for that particular clinical application, but it really can be applied to any soft tissue organ surgery. And then our protocol itself can be applied to any image guidance system, kind of regardless of the procedure.
Right.
Yeah, just to chime in real briefly here, we have had a lot of interest among our lung surgeons in this, but lung is really hard because the tissues deform so much. But we would love to do, VATS type procedures with robots in the lung, but it's just going to require a lot better soft tissue modeling. So we're not actively working on that, but we've done some early preliminary work along those lines. And then with other non-Da Vinci style robots, we're looking at prostate registration as well from inside. We're doing a lot of endoscopic prostate procedures. So we're looking at this same kind of protocol for registering images there.
And maybe a quick follow-up. So for registration, do you have any target? Like what is accurate enough? I know you had a few millimeters, which seems very good, but is any accepted target? Like if you get this, then.
So for our work, it kind of differs whether you're working in phantoms versus you're working clinically. So we were getting down to a few millimeters of accuracy when we were registering phantoms with our touch-based approach that I mentioned in my presentation. That's really the way we went about it in clinical use as well. We wanted to utilize that touch base so we weren't actually disturbing the kidney tissue in any way, and leveraging the robot that we already had there for surface digitization. So we don't have any real true way to measure how accurate the registration is in vivo. The best way to do that would to bring in like a C-arm CT machine or something, but we aren't able to do that during actual surgeries. So we kind of just visually analyze and take a second. The surgeon will sort of, point their tools at the anatomy, and they'll be the ones to visually verify that they're okay with the registration moving forward. Kind of as a team, we all agree that we have a good enough registration, and then we move on as far as the in vivo setting goes.
Great, thank you.
Yeah, and I think your question was also how good does it need to be, maybe, to translate clinically. It looks to us, we haven't been able to measure this exactly, but it looks to us like they take about a 5 millimeter or so margin of healthy tissue around the kidney, around the tumor, roughly speaking. So we need to get this to a level of accuracy to help the best surgeons where we could cut it down to say 1 or 2 confidently, which we're not there yet. But the other big win here would be if we can just give surgeons enough confidence to even take the 5 millimeter margin confidently that they won't give positive margins, because there's a lot of surgeons that just don't even do this procedure today because they're just not confident enough in their own ability to get the right margin. So we would love more patients to get partial nephrectomies. And if we can even get the average surgeon up to sort of the standard of the best surgeon, that could spare a lot of patients, parts of their kidneys.
Great, thank you.
I had one question for Matteo. So thanks for your very nice modeling and experimental work. So if I understood correctly, the framework you have now is for characterizing different scaffold designs, and to use this framework for optimizing, if you will, or refining the design for different settings. Do you envision potential then also use in the longer run, just in the theme of this webinar, using models to also guide sort of implantation for different patient-specific cases, or any thoughts about that?
Thank you for the questions. Really interesting. Yes, so you have many different materials, so there is a lot of research in the material, but also the architecture and also the site of implantation are something interesting. So we are also working on the biomimetic design of these magnetic scaffolds, and we would like to account for the actual implantation. We are working with some orthopedic surgeons to do that and to simulate what would be a real environment and an actual hyperthermia treatment with those scaffolds, with some realistic tumor shapes and with all the tissue surrounding. So yes, there should be this numerical study to at least translate this interesting idea in the clinical field.
Okay, thank you. We're looking forward to seeing that work in the time ahead. Yeah.
Thank you.
I think we've reached the end of our 1 hour presentation and discussion slots. I would like to thank all of our presenters, also all of the attendees for attending. Thank you for your excellent work. I would encourage all viewers, also offline online viewers, to look at the papers which were published in OJEMB. And with that, I don't know, Paolo, do you want to say any final closing words?
I'll just thank you and Punit for pulling this together, and the speakers for really excellent talks, right? So this will be posted on the journal website just in a couple of days. So looking forward to having the recordings there. And thank you very much to people who attended today.